called the crisis, and it's called the Crisis Response Center, or CRC, and we serve anywhere between 800 to 1,000 people a month, mostly adults. So about 600 to 800 adults per month, and then 200 to 300 youth per month. And it was built by Pima County in 2011 using bond funds. So the bond funds built the actual building, but the services are funded via our Medicaid system. And so it's basically on the campus of the county hospital. And the county hospital has long contracted with the University of Arizona, which is now Banner Medical Center, to run the hospital services around it. And then the CRC was built on that same campus, but run separately. And my organization, Connections Health Solutions, actually operates the CRC. And it was really meant to be a way to provide an alternative to police bringing people to jails and emergency rooms, and also an alternative place for people to come too. So people can arrive either from police drop-off, from walk-in, from mobile teams dropping them off, or transfers from emergency rooms. And we have, for both adults and kids, a couple different levels of care. So the first is for our lower acuity people, is 24/7 walk-in urgent care. So anyone can walk in, say they're new to town, need to be connected to services, need a med refill, miss their appointment, can't get in to see someone. And so they'll typically, on average, are in and out in around 2 hours. And so they see one of our case managers and then see either a psychiatrist or nurse practitioner, get their medications. Sorry, my cat is being very vocal. And to get their needs met that way. And then the heart of the operation is really the 23-hour observation unit. So these are for people who typically would be boarding in an emergency room. So people who are danger to self, danger to others, agitated, violent, psychotic, intoxicated, needing withdrawal services. And they basically meet criteria for being in an inpatient unit. And so those folks go into our overnight 23-hour observation unit. And there we have an interdisciplinary team. We're staffed 24/7 with psychiatrists, nurse practitioner, nurses, behavioral health techs, case managers, and peer supports, who are super important, people with their own lived experience with mental illness or substance use issues. And our philosophy is that most of those folks don't need to be in the hospital if you start treatment early and aggressively. So our door-to-doctor time is right around 90 minutes, so we can start treatment early. Our social services staff is immediately on the phone with families, talking to the clinics, trying to figure out what's happening in that person's life and what services they need. Our peer supports are doing groups or doing one-on-one interactions with people, really trying to engage with folks. We have a lot of people who have co-occurring substance needs, so we can do medically supervised detox. We can start Suboxone, and so our nurses are hard at work handling that. And then our behavioral health techs keep the unit safe, and so everyone's under constant observation. It's an open area with recliner chairs. The reason it's open is for a few different reasons. Is because if you're trying to keep people safe, then how do you keep people safe? Well, you watch them, you keep them under observation so they can't hurt themselves or others. And so having everyone with constant line of sight with our staff is how we do that. And also, so that if you think about what happens when you go to an emergency room, if you're suicidal, they put you in a room by yourself, they take all the stuff out of it, they hire a sitter who's supposed to watch you but not talk to you, and you spend like 12 hours in isolation waiting to be shipped somewhere else, which is not very therapeutic. So with the open area, people can walk around and interact with other people, our peers, or talking with people, playing games with people, doing groups, things like that. And then finally, it's open because we never go on divert for the police. We're never full. So having that open area as opposed to just beds allows us to flex when we have surges in volume, and we can be flexible. For adults who need to stay a little bit longer, then we have a short-term inpatient unit for our adults. and people typically that's a normal, like, looking inpatient unit with separate rooms and beds and things. And people tend to stay on that unit for around 3 days, and then we can we can transfer to all the different psych hospitals in the community, and so we send people out as well. A big piece of this is the no wrong door, which means that we're trying to keep people out of the justice system and keep them from being arrested. Then it's part of our philosophy is that we treat law enforcement as a preferred customer, just like we see our patients as preferred customers. And so, what does law enforcement want? Well, y'all want to get in and out as quick as possible, not have to have a whole bunch of hassle about taking your guns off if you're walking through the building, and all the, parading people through the waiting room, with everyone, watching. So we have a dedicated law enforcement entrance with a secure sally port, and we get law enforcement in and out within typically 5 minutes or less, 6 minutes or less. Our target is 10 minutes, but we're typically below that. And the other thing is that we never turn law enforcement away. And with crisis facilities, there's a lot of variation. What one place may call a crisis stabilization unit in one state may look like something completely different in another state. In our model, like we really focus on those highly acute people. And so we want the agitated people who may be violent, intoxicated. We, many places will say, well, we can't handle that acuity and those people should go to the emergency room. But our philosophy is those people are most in need of specialty care. And so we want those folks with us because we have the setup, the physical plant, the staff, the training to be able to de-escalate those folks and get treatment started so they don't end up, being like restrained on a gurney in the ER. So, and we don't use security. I mean, we have security like in the parking lot and stuff, but not on the clinical units. Our philosophy there is our clinical staff is highly trained. And so why would we default to somebody with less specialty behavioral health training to manage agitation when we should be able to do that ourselves? And so it's a big core part of how we function is that no wrong door. We take everyone. We never turn law enforcement away. So if someone may have people always ask, well, what if they have a medical issue? And first of all, our CMO likes to remind us psychiatrists that we did go to medical school. So we can treat some basic, health things. We can treat high blood pressure. We can treat high blood sugar. But even if they do, and also the police don't get enough credit for knowing who has a medical emergency and who doesn't. So only about 4 to 6% of people that we get do we send over to the emergency room for some kind of evaluation, and then we always take them back. But to us, it doesn't make any sense to then tell the officer, oh, this person's medically unstable, you bring them somewhere else. We take that person in, and then we get all of that arranged. Same thing, if maybe they would be better served at the substance use facility that's across town. We don't tell the officer, oh, you should take them over there. We take that person in, and then we'll work on getting that person transferred. So that's a big part of that, no wrong door, is that we don't put the officer in the position of having to figure out where to take people. We just take whoever they bring us. As far as how we're funded, I think it's important to note that Arizona has a really robust crisis system already, and we fit into that. And that crisis system is funded kind of pretty much on the backbone of Medicaid. So the state Medicaid agency, which is called Access, they braid together funding from a variety of sources, Medicaid funds, but also the state block grant funds and the federal block grant funds and some state and local funding. And then they contract with the regional behavioral health authority for each part of the state. And then that regional behavioral health authority contracts with providers like us to provide the services. So the county built us a beautiful building. They lease it to the REBA for $1 a year, which is awesome rent. And then the services that we provide, so the county didn't have to figure out how to fund all these services forever. They just had to come up with a capital expense for the building, because all of the services come via the healthcare system, via the Medicaid system, so their healthcare dollars, which I think is important to note, because we don't see counties going, well, where in our county budget are we going to divert funds away from, the police or something so we can pay for all these heart attack patients? Like, that makes no sense. You expect the healthcare system to pay for healthcare. And so it's the same for behavioral health. So that's kind of just an overview of, we are part of a larger system where there is a crisis hotline. They get about 6,000 calls a month from people in Pima County. They're able to, and 988 now points to that line. They're able to resolve about 80% of those on the phone. There are about 12 to 16 mobile crisis teams that are clinical, and so not law enforcement, like co-responder teams, but true clinical mobile crisis teams. And the crisis line can dispatch them, and when they do a face-to-face, they resolve about 70% of those crises out in the field. And then our crisis facilities, of everyone who walks in, we resolve about 60 to 70% of those without someone having to go to inpatient or to a higher level of care. And then at every point along there's easy access for law enforcement. That whole idea of, we treat law enforcement as a preferred customer to reduce people ending up in jail is kind of baked into the whole system. So some of the crisis hotline staff sit in the 911 call center and are able to divert about 1,500 calls a month into that clinical system. There are the mobile crisis teams. They, like, their contracts say that they have to respond faster if law enforcement needs them in the field than to just like a regular call. And then there's some various co-responder teams that do a lot of outreach and follow-up that Jason can tell you more about. And then our crisis facilities, we resolve about 60 to 70% of those, for people who come in to see us. So all of these things together kind of work as this organized system around decreasing people ending up in jails and hospitals and ERs. And I will hand it over to Jason because I just did a lot of talking.
Good morning, everyone. I'm Jason Winsky. I'm a sergeant with the Tucson Police Department here. Just to scale that for you all, we're about 750 officers serving a population of about 500,000 people. In 2013, we started, along with our Pima County Sheriff's Department, both our police and Sheriff's Department here, started dedicated mental health support teams. And where we started really was just with myself and two officers serving the involuntary commitment order. So whether you call that court order treatment or assisted outpatient treatment, AOT, that's really where we started. And we dressed down in polo shirts, just like what I'm wearing now. And all we did was we brought people to the CRC all day. We would do voluntary transports, we would do involuntary transports. And we really started kind of data mining that population, and we realized that we were taking a lot of the same people over and over again. But the CRC opened in 2011, right, Margie? That's when it opened. And so it had already kind of got its feet underneath it by the time that we started our team. Like anything else, the first year that it was open, there was a lot of, bumps in the road. But Margie and her team came in and really kind of course corrected it. And it turned into this place where it's absolutely no wrong door, where we can take anyone of any acuity. And eventually, after my team got its feet underneath it, we added detectives to the unit. And that was really interesting because they do kind of the wraparound piece. They do the friendly faces, the people that we're interacting with over and over again. And so they work with the staff at the CRC all the time doing, deep dive cases of who are we bringing here and why, who is hitting the jail system too often, who is hitting the 911 system too often, who is going to the CRC over and over again. And so in collaboration with our fire department here, we actually ended up, doing like a high utilizer project, which we call Friendly Faces now. I keep getting reminded about that. For us, the centerpiece of the crisis system here is the CRC, the Crisis Response Center, where we can take people, no matter what the condition is happening, no matter what is going on with them, even if they're very agitated. And it's been very, it's been a great journey for us. A big thing for us too in Tucson here is we're big fans of co-responder. So after we started the mental health team, a few years later, we added a substance use resource team. And then about 2 years ago, or 3 years ago, actually, now we added a homeless outreach team. And so all three of these teams are in the community all day, every day, doing outreach, doing overdose prevention, trying to get people into housing placements, taking people from the community to places mostly like the CRC. And we added co-responder programs to all three of them. We have clinical support for my team with our crisis mobile teams. We have peers that work with our substance use resource team. And we have peers and navigators that work with our homeless outreach team as well. During COVID, unfortunately, we lost our co-responder program on my team, but luckily the community kind of rallied together along with people like Margie, and we wrote a grant, a BJA grant, and we're happy to relaunch our co-responder program. I think, hopefully, knock on wood, this coming January, we'll have that back up. So, I'm really proud of the work that we're doing in law enforcement out here, but it really doesn't work if you don't have a place to take people that's no wrong door. And we have tons of clinics in Tucson and in our community that are doing great work, but most of them are not no wrong door. The centerpiece of our crisis system here is really the CRC, where we can take people, the officer, what we train in our crisis intervention training, and I love how Margie says, CIT for us is not just a training, right? It's supposed to be like a community-wide program. And what we train the officers is, when you have that no wrong door resource, the officer doesn't even really have to think, where can I take this person, or is this person going to be the right fit for XYZ? If they see the crisis and they recognize the crisis, and we've trained them to do that, they know they can go right to the CRC. And that's been very beneficial for us. I already see some questions in the chat. I answered one of them.
Yeah.
Hi, Melissa. Good to see you again, by the way.
If I can distill that into something that might translate to multiple jurisdictions, I think a lot of sites are very anxious about taking folks with aggression or that are involuntary. Can you talk a little bit more about like what training might look like, how you kind of were able to set that expectation, and then how you hire and train to be able to kind of do that?
So, and I didn't do I just jumped right in and didn't even really introduce myself and my organization, which kind of gives you some background as to why we were able to do this. So I'm a psychiatrist. I work with, right now my title is Chief of Quality and Clinical Innovation, but I joined the organization in 2014 when we were asked to take over the CRC because of safety issues and just process issues and things like that. And a lot of that was because they weren't set up to take the acuity that they were getting. And I think it's really important to the term crisis stabilization unit doesn't really mean anything because they're so different everywhere. And one of the things we're advocating for is to set some standards. Like everyone knows in emergency medicine world what a level 1 trauma center is versus level 2 trauma center, level 3. And I think we need something like that for crisis. But our history, so Connections Health Solutions, we were founded by 2 psychiatrists who were still with us, and they pioneered this high acuity observation model in Texas, in the Dallas-Fort Worth area, and then brought that model so Dr. Carson, our co-founder, came to Arizona and was the CEO of the Regional Behavioral Health Authority there. And there was a crisis facility in Phoenix, this is like mid-2000s, that existed, but was not functioning well. The police wouldn't use it because they were turning people away all the time, and a lot of different problems. And so he brought Dr. Williamson out from Dallas, and the way he tells it is like Robert says, Dr. Carson just dropped him off out front and said, "See you in 6 weeks, fix it." But that's what he did, and he got it to that same model of taking the really high acuity people. And once and I'll talk about what that entails in a second, but once that facility was doing that with the 5-minute drop-offs and then taking everybody, including all the agitated folks, and treating them safely, that became the expectation in Arizona. So kind of like the rising tide lifts all boats. And so all crisis centers in Arizona, well, I mean, not all of it. It's very clear that there are some that are set up for the involuntary high acuity population, and that then those ones do take everyone, and that's the expectation because it's been demonstrated that that's possible, and that's sort of the Arizona standard. As far as how we do that, so like I said, our staff gets a lot of training. The training that we use is called everyone gets therapeutic options, which is like a trauma-informed verbal de-escalation kind of training. And then our behavioral health techs get a off-the-shelf training. It's called Safe Clinch, CLINCH, and which is a really great training. We were doing CPI, which a lot of people may have heard of, Crisis Prevention Institute. We found it really wasn't adequate for the types of patients that we have, and so we switched over to that. But it's not just doing the training and checking a box. Our techs, like, I mean, I think the state requires you get training like every year, but we do it every 6 months. They do drills every month. We look at video of all, and every time that there is a hands-on, so that we can learn from it. And so we have a whole quality improvement process around that piece of it. And the other, so that's part of the training, but then it's just also built into the clinical model. Like, our philosophy is that we want those high acuity people, and so we're staffed to be able to accept them. So we have 24/7 on site, either psychiatrist, nurse practitioner, or PA, or so that if we need to give medications quickly, we can do that. We're set up, we have we're joint commission accredited. So there's sort of like, sometimes I call it like it's like a false dichotomy between recovery model and medical model. And some of the mistakes we see is people go, we want to be recovery oriented, so we're not going to do all these things, these hospital-like things. But then that means you're refusing all those people that need that kind of care. So I see it more as like Maslow's hierarchy triangle, where at the base we have hospital level safety. So we're Joint Commission accredited. We have automated med dispensing like a Pyxis, and 24/7 nursing and provider coverage. And so then we layer the recovery oriented services on top of that. Also, I think it's really important that I think it's good to have a continuum of types of facilities. So not everybody needs this highest acuity level. If you are just someone who really just needs peer respite and needs kind of a safe place to be and get some peer support, and have a cup of coffee, and and that's all you need, and you're not really highly acute, then it's probably overkill, and probably not the best experience to be in a high acuity facility like this. But you need one, I think, in a community that takes those high acuity people, because otherwise they still end up in emergency rooms and jails. And then a community is like, well, why do we spend all this money on a crisis center when we still have these problems that we thought it was going to solve? And then the involuntary piece, I'll just talk about that for a second and then end. But one of our core values is we want to do care in the least restrictive setting. So that's why we try to resolve that crisis. We don't assume people are going to go to the hospital. When they come to us, we assume we're going to resolve the crisis, do all that we can to resolve it, reassess them at some point in that 23 hours. And then most of them are getting better. And then we can work on a discharge plan. If they're not, then we pursue a hospital placement. One of our core metrics is converting people to voluntary status. So we get people who come to us on an involuntary hold. And again, even if they do end up going to the hospital, we're trying to do that least restrictive care. So most of them, that stat is also around 60 and 70%. We were able to convert them to voluntary status. And so if you, and we've actually just did a research study that shows that those people that we do convert to voluntary status have less readmissions than people who started voluntary with us. So if you build something that excludes that involuntary population, it's like you're depriving them of the opportunity to be engaged into voluntary care. And if they go to an ER where they're not really going to get, there's not really the capability to do actual treatment, they're just going to be shipped off to a hospital. And and it's like a snowball, like once they're on that involuntary track, they kind of continue it, versus get some treatment and maybe they don't have to, have their rights taken away to get the care that they need.
You have Melissa with her hand raised, followed by Willa. So I'll just have you guys come off mute one at a time and pose your questions or join the conversation. Melissa?
Hello? Hello, can you hear me?
Yep.
Yep.
Yes, so doctor, can you repeat the organization you work for, and if there's any way we can maybe provide website information or further information about your program?
Yeah, I'll put it in the chat. It's Connections Health Solutions.
Connections Health Solutions, okay.
Yeah, so it's Connections HS, and I'll put that in the chat. And so we have our Tucson facility that I just talked about, but we also have our larger facility in Phoenix, and then we have we're expanding. So we have facilities under construction in the Seattle area, Northern Virginia, and then hopefully Pennsylvania also. So, and then as far as site visits go, we are one of the learning sites through the BJA, with the Council of State Governments that administers that. We'll put that in the chat too. So you can do site visits through that learning sites program. And then not only do you see the facility, but you get to go on a ride along with Jason's people. People often want to go see the 911 collaboration. So it's a site visit for kind of the whole crisis system when you do those site visits.
I really appreciate that. Here in Delaware, we do have a recovery innovation site here. Myself and my partner are on this session.
Cool.
We're part of a co-responder unit. So I do ride with a mental health professional, and we do respond to calls for mental health crises in our county. And yeah, your organization sounds like something that we need here in Delaware, especially for individuals who need a higher level of care or in an extreme crisis that we could, uh, you know, transport directly to. Because unfortunately, at times we are turned away um, here. So I like the what you've presented today.
Thanks. Yeah, and as we go, like so, we're expanding into other states. Crisis is really nationwide is undergoing this huge expansion where because of 988, because of more federal funding coming down, because of policing reform, of trying to have a health response rather than a law enforcement response. So states all over the country with 988, they got planning grants to start to plan these crisis systems. And what we're finding as we go into other states that we're having to help them figure out the licensing and the payment because they're not set up to do that yet. And so, like some sites, like Virginia, for example, like we're having to work with them because I was saying we have the ability to dispense meds right away if someone comes in really agitated. Well, like their regs don't allow you to have the meds on site like that. So like we're having to say, well, we can't do this successfully unless these regulatory barriers are addressed. And so it is it's important, I think, to if you're going to do these really high acuity centers is to have everything set up so that you can actually do it. Otherwise you get mismatched expectations.
Yeah, and that's right where the work is, right? And that's so frustrating when law enforcement's genuinely at the table with a co-responder program and you're seeing the crisis, you're recognizing it, and you just want that person to go to the right place. And if that place isn't there or you get turned away, I totally hear you. That's very frustrating.
Oh, Melissa's back. Her Wi-Fi is back.
Okay, thank you. So what I wanted to find out is, so currently what we have is a psychiatric urgent care, which, so they don't take people that are in imminent danger to self or others. and the people that have any aggression at all. And so those folks, generally, they go to the ER. And I'm just wondering I know that part of our problem, I heard you talking about the amount of training that the staff have at the CRC. I think part of our problem is that here we've got a lot of turnover, employee turnover with the LMHA. And so y'all are not the local mental health authority or provider
Right.
contracted, right?
Yeah, so yeah, every state does their whole mental health system differently. A lot of the Western states, and Arizona is one of them, does things via managed care. So our regional behavioral health authority does not provide the services. They are basically the payer and the regulator. And then all of the services are provided by various private organizations who contract for that. So we're one of the contractors.
Okay, so then you said that the facility was built by bond funds, and then the services are paid by Medicaid.
Right, which
Um,
doesn't have to be. Our Phoenix facility is like, we lease that space ourselves. It wasn't like provided by the county, but $1 a year rent, you can't beat that.
No, yeah. And then I guess my other question is like to hire an organization, to contract with an organization to do a facility. Are there additional costs other than than the treatment fees, the Medicaid billed fees?
The way Arizona does it is that they braid together funds from a variety of sources. So like in most states, like what the local mental health authority gets, that money comes from the SAMHSA block grants that the federal government gives to the states, and then comes from stuff in the state general revenue. And then Medicaid is usually separate and a whole separate department and everything. The way Arizona does it is all that money flows to the Medicaid department, and then we get paid up front because they're paying for capacity. So it's a firehouse model. They're not paying me to see someone at 2 a.m. and then submit a bill and then get paid 90 days later. They're paying me up front to be there at 2 a.m. And then we show all of the work that we do and all the encounters that we have. And then there's a financial reconciling done that shows that we did enough work to justify what we got. And then they allocate, oh, these 500 people had Medicaid, we'll put them on that spreadsheet bucket. And these 200 people didn't have Medicaid, we'll put those on the SAMHSA block grant bucket. And so all that's done kind of on the back end. There's other ways to fund. So that's how Arizona does it. And that's, I think a really good model. For states that aren't set up that way, a lot of states, or a lot of crisis funding, a big opportunity is the CCBHC model.
Yeah.
Where and there's different ways that the CCBHCs are funded, but the ones that are on that prospective payment system, so the ones are mostly, it's like the demonstration states, where there's a need, the state does a needs assessment, and then they and the CCBHCs are required to do crisis services. The bare minimum, they're supposed to coordinate with 988, they're supposed to offer 24/7 mobile, and they're supposed to have at least a walk-in urgent care for voluntary people, but they can do more. And so for that, they calculate the total cost, including non-billable stuff. And then they get a monthly per member per month payment for that. And so like Oklahoma, for example, is building out with a pretty well organized system that, when it's, they're sort of in the beginning phases of this, but they've done a lot already. That would be a robust crisis system similar to what we have in Arizona, but they're funding that via the CCBHC model because it allows you to bring down Medicaid match for funds that currently aren't Medicaid billable. So there's all the states are innovating and figuring out different ways of funding crisis.
So would y'all consult with Texas on how we could figure this out? Because that's been a struggle. And I know that you said Dallas, you've done something there.
Yeah. I'll put my email.
We can connect afterwards. Yeah.
Yeah. And I'll put you in touch with our growth team that does all of that. I know where in Texas are you at?
Austin, Travis County.
Oh yeah, a whole bunch of y'all came out and visited us.
Yeah, we did. Yeah.
Like it was like half of Austin was there. It was like
yes, it was.
Yeah.
Yeah, thank you. And then one other thing. So Jason, our currently with our psychiatric urgent care, and we also have an extended observe unit with 4 beds maybe. The officers actually have to take people to the hospital ER and that are on emergency detentions, and then the hospital ER social worker calls the LMHA's utilization management to staff the case to find out whether or not they could go to one of the crisis units that's like, an extended observe bed or something else. And then if they qualify and they've calmed down enough, then the officer has to come back to the ER and pick them up and take them to the second place. And so that is
Yeah.
a big deterrent.
Yeah, I was going to say, so that means the cops probably just don't even bother with that most of the time, to be honest, right?
Right. So that's where I'm trying to help move us towards taking the emergency detentions, because it's a big deal.
Yeah.
And now
Makes
we've got a
sense.
new law that if anyone assaults, if any person that's in the hospital assaults any staff member there, it's a felony.
Oh,
Well, that's just
So-
setting people up with mental health issues.
well, right.
Yes.
Yeah.
Yeah, so it's much wider. So I'm looking to see a lot more of that. And I'm hoping
Sure.
that we can find the ways to prevent that soon.
Yep.
So thank y'all.
Willa has patiently had her hand up.
Hi, thank you.
We should reward that.
I have 2 questions, if that's all right. So I come from a pretty rural county. Our regulations in the state are catching up. We are actually in the midst, probably in the next couple of weeks, of the county opening a crisis stabilization center. And I'm from mobile crisis, so I'm on the other end of that. And we're very much looking forward to an alternative destination to the emergency room. So one of the things we're running into, and I don't know if maybe this didn't apply to you guys or not, but have you had to get creative at all with trying to staff 24/7 teams with clinical and medical professionals? We're struggling.
Yeah, everyone is struggling with workforce, right? So, we do use, like I mentioned, that we use a mix of psychiatrists and nurse practitioners. So we do, use a lot of non-physician providers, and we've been working through the best way to make sure that they're getting adequate supervision, because I think the type of training that they're coming out of school with has sort of changed over the years. But so we're making sure that they kind of have an onboarding process where they are shadowing and learning our model. Peers are a huge part of our workforce. And then we've been really working hard to have a career ladder so that people can move within the organization too, because that's where you get turnover too, is when people feel they can't advance. And so, we've been doing that both within a discipline, and then for people to want to go from say, for example, from being a peer support to a case manager. For rural areas, rural is more, I forgot to mention that we also are doing mobile in Montana. So that's pretty rural out there. And in rural areas, it's that staffing, especially the 24/7 nursing piece that is, if you don't have a nurse, then you really can't be open. And so for that, you've heard the term empath unit. It's basically a unit that's like what we do, but attached to a hospital. And so the guy that sort of coined that term, he's a psychiatrist named Scott Zeller. I know him very well. And he's sort of coined that term, but it's basically a crisis, like a 23-hour OBS unit that is attached to a hospital. And for rural areas, I think that makes a lot of sense, because you've got economies of scale. Because where are the nurses in a community? They're in the ER in the middle of the night. So if the OBS nurse called off, to have some arrangement where there's some cross coverage. So I think that makes kind of sense in rural areas and then the physician part could be, via telemed, but rural areas, you do have to get more creative. And I think you have to glom on to something that exists already. Out in Yuma, it's a lower acuity crisis unit. It's more like a living room. but it's everyone's clear on like that's, you know, you don't take high acuity people there, but they do some creative stuff, like the mobile team is based out of there. So when they're not off doing mobile crisis, then they're in there. And so there's, you know, some economies of scale that way.
Well, thank you. I think one of our other issues is competing with private practice when it comes to licensed social workers and licensed counselors.
Yeah.
Pay rates.
Yeah. And so and we do, you know, in Arizona, all the states have it, like whatever your qualified mental health professional. So we have people that are working under the supervision of someone licensed. Well, not everybody is licensed, because yeah, that's like, to have everyone be licensed is kind of, the workforce isn't there for that.
Yep. Thank
And
you.
peers are a great way to extend your workforce too.
We've been
'cause they do a lot of really great work, and then we train them up to be case managers, and then, you know, they could keep advancing.
exactly. We see a lot of value in peers for sure. My one other question was for you, Jason. This is going to sound kind of weird, but how does police transport specifically voluntary people? And I'm asking because in our county, it is policy that they are handcuffed if they're in a police vehicle. So therefore, we're using EMS to avoid handcuffs, but that's just tying up EMS additional resources, you know?
Yeah, so we struggled with that for several years here in Tucson. So for the data kind of varies, but almost half of our transports to the CRC here are voluntary. And that was kind of a question that was posed earlier too. You know, we've had CIT training here since 2001. So if you work anywhere near law enforcement, what that means is with our retirement rate and our turnover, like we still have the 20-year retirement here in Arizona. So, I mean, we have a whole generation now of law enforcement, essentially, right, that's CIT trained. And it's a combination of they're trained to see the crisis, and they also know this tool exists that just works in 5 minutes or less for a drop off. So, you know, they go to a 911 call, or they see someone at a Circle K or 7-Eleven or what have you, and the person might say, can you please take me to the CRC? Or in most cases, the officer suggests to the person, I think you could use some help. How about I take you down to the CRC? It took almost 3 years of me arguing with our police lawyers for me to get to a place where we could have a policy actually where we don't have to handcuff the voluntary transports. It's a game changer. It's very hard to change police culture that way, though. You know, if you're in the back of the car, you're in handcuffs, right? So it took a long time to get there, but we finally did.
Cool. Thank you. I'm going to bring that up to our local law enforcement.
Yeah.
If possible.
Yeah, and Jason shares that policy all the time if you ask him for it. And
Yeah.
then if people do come in handcuffs, you know, we on our end feel like there's a very bright line between being in custody and being a patient. When we've seen facilities that are having troubles, that line is blurred sometimes, where it's like, you know, the staff is wanting the police to leave them in handcuffs while they give them meds or you know, like we don't, but we're like, no, like we want to get you out of custody and into treatment as quickly as possible, and also send a message that this is for treatment, this is clinical, it's not, you're not detained. So if they do come in handcuffs, it's actually our staff have a handcuff key, and then in collaboration with the officer, then it's our staff that unlocks them to send that message.
I love that. I love everything about what you guys have described. It's so much more humanizing than the ED experience for sure. You guys are doing really great work. Thank you.
There was a question in the chat about people with IDD and autism. And yeah, we take anyone who lands on our doorstep. So, and we do get, especially in our youth unit, you know, kids with IDD and autism. And I will admit that is a very challenging population, because often what they need is not to be in a mental health hospital, but you know, they need respite or they need more in-home services. But at that point, wherever their placement is has gotten overwhelmed and they can't, you know, handle them right then. So we take that, you know, we do take them. We work on a on a case-by-case basis on how best to work with that person. We try to get their behavior plan from wherever it was that they were staying, figure out, do they use iPads or communication cards to communicate? We've invested in things like weighted blankets and vests and stuff. Oftentimes, depending on the severity, like that person may need to be on a 1-to-1, but we work on we just try to figure it out. And we've tried to bring in some external, training around that population. I'd say that population, and then they get stuck. We're a 23-hour observation unit, but if no one else will take the person, and placement, like the clinic is like, oh, well, maybe in a week we'll have placement. They do get stuck with us, but that's super challenging. There's a chat question. I heard you say that on occasion you have to send a patient out and then bring them back. Does the CRC provide minor medical clearance? Are there any disqualifiers for law enforcement? Does the CRC follow under EMTALA? Technically, I don't think we're under EMTALA. We kind of act like we are, though. I mean, we take everyone, and then if we're gonna, we don't just turn people away. If we're gonna send them somewhere else, it's a formal transfer. The CRC, like we were saying, is right on the campus. It's like actually connected to the ED next door via a breezeway, even though it's like a different hospital with a different license and a different operator. We work really closely with that ED. We meet monthly with their medical leadership, discuss cases where there was disagreement. That relationship was very when we first took over the CRC, there was it was not a good relationship, and then we worked for quite a long time to get to the point where now the two sides, the two organizations, there's trust. The people in the moment, the staff knows to just do what's right for the patient, take the patient, whether it's the ED or us, and then if they have any issues, to email their medical director, and then we work them out in our meetings. We have protocols for getting people over there emergently versus urgently versus routine. We've worked a long time on that. The term medical clearance, I don't even like that term, because the literature, doesn't really mean anything. There's no reason to do a whole bunch of blanket labs on people just because they're psych patients. And so when they come to us, they don't have to go to an ED first. They come to us, directly. But most people, like I said, don't end up needing to go to the ED. When they're evaluated, by our providers and our nurses, if we identify minor medical issues, then we address the things that we can. So, like we get people started back on whatever their home meds are. If they've got if they're hypertensive but not symptomatic, we can treat that. If they've got minor skin infections, we can treat that. One of the protocols we worked out with the ED next door was, they thought we were sending people over for high blood sugar that we could manage. We worked with them to develop a better protocol and better criteria. We got ketone strips, to help determine who really needs to go to the ED. So that's kind of how we work stuff. There are a few things, and like I said, Tucson police, the officers are pretty good about knowing what we can't handle. There's a few just mostly nursing things that we try to say, let's figure out how to say yes rather than look for reasons to say no. So if someone say they have an ostomy or something, but they have the supplies and they know how to maintain it and they can do it with some help, then we try to work out a way to take that. There's a few things that we can't do, we can't do IVs, we can't do oxygen, because even if that person's calm, another person could pick up the tank and hit somebody with it. We can't do active TB. We can't do, people have to be able to do their ADLs with some assistance. We don't have a lift for someone who's total care. But for the most part, if they're well enough that an ED would send them home, then they can be with us. And it's really nice to have the ED right there, but it's also not necessary. Our Phoenix facility, the ED is 5-10 minutes away. But again, we work on protocols with them, and we can get people moved over, and then we always take them back, because no one likes to feel dumped on, right? So if we send the ED to the ED, we're sending them for a specific reason, because we think that something needs to be evaluated and treated, and then we take them back. We don't go, oh no, they have to go over there and they're done. It's if you can address this medical issue that we identified, we're happy to take them back.
Hey, Doc, let me ask you another question. This is Ernie Stevens again. And I ran into this one time, so I'm wondering what your what your protocol is. But what if, and Jason, you're laughing because this one's coming to you actually. What if law enforcement picks up an individual on the street and they have an animal with them?
Oh,
Yeah, what do you do with that? What they say, what they claim, hey, this is my service animal. Logistically, these don't happen very often, but when they do, how do you make sure that you're staying within compliance? And then how do you accommodate that situation?
you tell them about the lap dog?
Yes. Yes, we have on occasion brought service, quote unquote, service animals to the CRC, and they're very accommodating. Thank goodness for that. We had a veteran actually a few years back that had what he described as a service dog. It was a very large dog.
It was a pit bull,
And it was a pit bull. And
which Jason told me it was a lap dog because it was in his lap.
well, because it was in his lap at, at some point, right? And we were in a standoff with this guy for, I mean, hours. And actually, I think at one point we put him on the phone with Margie, because he needed to know, I want to talk to the boss of the facility, and I want to know what's going to happen when I get there. And so we did bring his pit bull to the CRC, and they rose to the challenge. Our fire department here has a very similar program to what I operate, and they actually have placements for animals. So if it is kind of a pre-planned thing and we know there's an animal, we can work with our fire department's program here to shelter the animal while the person's at the CRC. But it's a challenge. It's absolutely a challenge.
Yeah,
It's
if they
definitely a
come
struggle.
with if they arrive with an animal, we have a contract with the kennel, so we'll offer to kennel it. If they absolutely won't, and it's a service animal and you can't separate people from the service animal, and there's questions you can't ask and all that kind of stuff, we just figure out a way to accommodate it. Our staff actually likes it when there's pets. And then we also there's an organization called Pet Partners. I think they're national. So we have our peers run this program. And so twice a week, people come in from the outside with therapy animals and do pet therapy too on our units. So we're animal lovers down here in Tucson.
All right, so to follow up on that, what happens, because we had both of these issues when I was doing mobile crisis. Someone with no supports admits that they need to go to services, the CRC, hospital, whatever is available, but they have minor children with them and they have no community to help watch them while they go. Do you have a plan in place for that?
Yeah, we work with DCS, and they can take them into temporary custody and have, they have shelter placements, respite placements, things like that. So
and also, Emerge. There's an organization here called Emerge. So if there's like a domestic violence nexus to what's happening, they do amazing work with like temporary placement and things like that. All right. I think are we at time?
We have some
I'm checking the chat.
Have additional questions, but if not, we don't have to stay on and stare at each other.
I would just like to say, with the thing with the DCS too, it works the other way also, because we have a youth unit. So if we get kids and we can't get the parent or guardian consent and can't reach them, we let the officer go, but then we have a protocol with DCS where they can consent so that we can bring the kid in.
Hey guys, on occasion, sorry, I love throwing these because this model sounds a lot like what we did here in Bexar County. They had minor medical clearance, they had sobering and detox attached to it as well. But every now and then we would get those situations where, when you're dealing with people sometimes on the street that are unhoused, that are married, and you've got to do an emergency detention or involuntary commitment on them. they were not allowed to we could not bring them both to our crisis stabilization center. Has that been an issue for y'all as well as you try to engage that population that's, seems to need those types of services?
Yeah, we've had couples, husbands and wives. We have an overflow OBS unit, so we try to keep them separate. And so if we could put one on one unit, one on the other, then we try to do something like that. I mean, we've had families bring their kids in and then find out that for the youth unit, and then find out that the parent needs involuntary care. And, I mean, we've had every scenario you can imagine.
Yep.
So we just try to figure it out.
Yeah, that was gonna be my follow-up question is, do you take in adolescents at your facility?
Yeah, we have this. Our youth unit is 0 to 17.
Got it.
It's mostly adolescents, although that like kind of 8 to 11 group has been rapidly growing.
You set off an alarm bell when you said 0, because I definitely got called to like evaluate a 2-year-old that was like not yet verbal, like was not delayed, just like a later talker. And the medical doctor was like, well, she just won't stop crying. Can you come evaluate her? And I'm like, what would you like me to use? So when he said 0, I was like, are you really serious?
Yeah. Well, so we have urgent care too. So I mean, so people walk in, right? So I think the youngest that's ever been on the unit was maybe a 5-year-old on the OBS unit. But we've had we had someone bring in like their 2-month-old, and our child psychiatrist kind of blessed them and said this is normal childhood development. And the person needed some parenting classes and some supports, obviously. But it's all ages.
That's awesome. That's something you can't do in an ER setting, right? Is like slow down and be able to
figure what does this family really need.
Yeah, so that's awesome. I'm not seeing anyone come off mute or chat in additional questions, so I will remain on the line so that the information, like the email stuff, stays in the chat. But I just want to take the time to thank you both so much for this chat. I think it's really nice to be able to hear from such a robust model, because folks are kind of struggling with like where to start or what's important. And you all have done the work of thinking through some of these crucial elements, like what to do with a lap dog and how to help like the whole family. So I really want to thank you so much for being here. Like I said, we'll wrap early, but I'll kind of chill here so that folks can continue to jot down email addresses, or if you think of a last minute question, I can forward it on to folks. But thank you both so much, and wishing everyone a great rest of your day and start to your week.
Thanks.
Good to see everyone.